So welcome everyone to our now third community discussion. We've had a couple of different names for these, but we found that to be the most appropriate. And this one, rather than focus on any one particular medication, we titled this an update on anti-amyloid treatments for Alzheimer's disease. Really want this to be sort of a recap of how we got to this moment in time, and with a particular emphasis on lecanemab and donanemab. And I'm here today with the co-directors of the Penn Memory Center, Dave Wolk and Jason Karlowicz. I'll turn this over to them in just a moment, but I did want to thank everyone for their questions. We asked for questions in advance, and my inbox was absolutely flooded with them. And so as an adjustment, what we won't do this time is have a kind of a standard Q&A portion. And instead, we summarized the major themes from all of the questions that were submitted in advance and incorporated them into the presentation. And I think we've done a pretty thorough job of capturing as much as that as we can. However, at the end of the event, if you feel that we did not answer your question or we answered it incompletely, please feel free to reach out. I'll have we'll have contact information on the last slide of the day. And if you receive Insight newsletter, you can just reply to that as well. I'm very easy to connect with. So just reach out and then we'll get you any questions you have answered. So with that, I will turn it over first to Jason Karlowicz.
Well, thanks, Terry, and good afternoon. I'm Jason Karlowicz, and I want to thank Terry Casey, who leads our communications operation, for organizing and putting together this community discussion. Joining me is my friend and colleague, David Wolk. Hi, David.
Hey, Jason, and welcome, everyone.
Good to see you. We're at our offices on Penn's campus, and it's a pleasure here to have this opportunity to give you all an update on anti-amyloid treatments for Alzheimer's disease. Important to disclose our relationships, particularly with the relevant companies that are producing these therapies. I'll leave these here for just a moment. I want to emphasize that information about these anti-amyloid therapies is available on the Penn Memory Center's website. This is a screenshot of our homepage, and you can see circled here in the yellow oval, the link to learning more about anti-amyloid therapies like lecanemab and donanemab. This presentation will be on that webpage in addition to the slides for later subsequent viewing. So I urge you all, if you're note takers, take notes, but if note taking is distracting, put down the pen, put down the pencil, and just enjoy the show, and you can come back and watch it later at your leisure. To review the agenda for today. So I'll update us with sort of the story so far about these fascinating, interesting, novel therapies, one of which is available for prescribing and one of which we think probably also will be available soon. Next, my colleague, Dr. Wolk, will give a presentation overviewing the results of the phase 3 clinical trial of donanemab, and then a comparison of donanemab with lecanemab, which, because of FDA approval, therefore is now able to be marketed, and the company sells it under the name of Leqembi. After that, Dave and I will get together and we're going to discuss the two drugs. As Terry Casey explained, we received a lot of questions, and Terry and I sat down, synthesized them into the following 6 questions, which we think sort of put together the themes of what you all wanted to know. I don't think it'll be complete and answer all your questions, and as Terry said, you'll be invited to, at the end, submit questions that have not yet been answered. And then we'll close with the story to come. That is to say, what's going to be the future. So that's the plan for today. Let's get started. Well, where to begin? Well, I'd like to begin with what our kind of conversations as a community about these drugs. Taking you back to the summer of 2020, some 3 years ago, we met to discuss the FDA's approval under the conditional approval regulations of the drug aducanumab. That drug has largely kind of faded from clinical practice for a number of reasons, which I think, given what we need to discuss today, are not worth detailing. But if you visit the aducanumab site on our webpage, you can learn more about the story of aducanumab. Fast forward some 3 years later, things got really exciting in 2023. In February, we had a town hall on lecanemab reviewing the results of the clinical trial presented of that drug. And as we expected, then things really got exciting in June and July of this year. So the FDA granted full approval to lecanemab. It had granted conditional approval early on. The field really wanted to wait for full approval, and we weren't surprised when it granted full approval to lecanemab in July. At that same time, in July, it's an exciting month, Lilly released the results of their phase 3 trial of donanemab at the International Alzheimer's meetings and in a simultaneous publication in the New England Journal of Medicine. David Wolk will be presenting the substance of that top-line findings. In addition to the FDA's decisions, Medicare made some very important decisions in June and July. First, it announced that it will cover a prescription for these for anti-amyloid therapies that have achieved full approval by FDA, and also a requirement that individuals receiving these drugs be enrolled in a registry that captures essential data about who they are, their criteria that got them into the study, and how they're doing. An important database so that we can learn more about these drugs. And in addition, Medicare announced that they would now reimburse the costs for a PET scan to measure brain amyloid. We're waiting on some final bits about that decision for precise matters, but the decision was a first step towards covering an important test that I think many of you already know about, but Dave will explain in greater detail. So those are the events so far. What I'd like to do is dive into two broad points about these drugs. One, the matters of their risk, and the second, the ways we talk about their benefits, and then I'll turn it over to Dave. First, we'll talk about overall their risks, and to frame that conversation, I'll speak about Leqembi's label from the FDA. As you know, when the FDA approves a drug, they write what's called a label. It's a description of who the drug is indicated for, necessary information around prescribing, a summary of its benefits, and a summary of its risks. At the top of the label of the lecanemab label is this warning. In sort of regulatory parlance, this is called a black box warning because it's at the top and it's in a box, and the box is black and bold. I don't expect you to read this text. On the next slide, I'll summarize it. But it's about the risk of lecanemab causing amyloid-related imaging abnormalities. And I'll summarize some of the key points up here. The key point of this summary is what is ARIA and its association with a very common gene. So lecanemab, this is all just taken from that lengthy text, which was literally lifted from the FDA label that I showed you. I have to minimize, by the way, image here. There we go. Lecanemab can cause amyloid-related imaging abnormalities, or ARIA. It's a quirky term. I find it quirky because it almost implies that the abnormality is something wrong with the imaging. That's not the case. Imaging is used to detect it. The abnormality is in your brain. And it can take one of two forms, either edema, small areas of swelling, that's what edema means, or hemosiderin deposition, which is a quirky way to say small areas where blood has accumulated, or microscopic hemorrhages. These areas of edema and microscopic hemorrhage, typically in the experience with these drugs plural, meaning anti-amyloid treatments, occurs early in treatment. Usually, and David will explain this in greater detail, these events are asymptomatic. They're causing little problem to people. Although, in some individuals, serious and life-threatening events can occur, and that's why it got this black box warning. These events can be serious intracranial bleeding. There have been fatalities. And these ARIA events can occur as seen with the anti-amyloid therapies in general. So both lecanemab, donanemab, and they were seen with aducanumab, the therapy that was approved by FDA in 2020. A key point, and this will be developed in much more detail across this talk, is that individuals who have a particular form of what's known as the ApoE gene, namely the E4 form, are at a higher risk of developing symptomatic serious ARIA. This can necessitate, therefore, the need to pause dosing, stop giving the drug, and sometimes, in the case, given the severity of the ARIA, treating the individual, such as with steroids. Therefore, the key point here is that testing for the ApoE4 gene should be performed prior to starting treatment. This result will inform your personal individual assessment of what's your risk. It's not required to receive the drug. With ARIA when deciding to initiate treatment. So this is sort of one of the hearts, if you will, of the kind of standard risk-benefit assessment, if you will, to decide if this drug is appropriate. So that's an overview of the risk. You'll hear much more about this subsequently. Now I want to just talk a bit more about the association with ApoE. ApoE is a gene. We all have it. It can take several different forms that combine two copies of these three forms, the E2, E3, and E4 form. All of us have two copies of the ApoE4 gene. So we have a 2-3, a 3-4, a 3-3, a 4-4, etc. As I already said, if you have the E4 gene, this is associated with two distinct kinds of risks. One of them is that risk of ARIA, the increased risk of microscopic bleeds and edema. There's another well-described risk with ApoE4, which is an increased lifetime risk of developing Alzheimer's disease. So let me repeat that. You have a gene whose results inform your risk of developing ARIA, but they also inform your risk, well, really your relative's risk of developing Alzheimer's disease, because an individual who would be considered for this drug has already developed symptomatic Alzheimer's disease, either mild cognitive impairment or dementia. So they would say, well, why? This isn't very relevant to me, but it's relevant to a family's discussion of the risk of developing Alzheimer's disease. So for example, a person who has two copies of the E4 gene, we call them an E4 homozygote. In other words, they have an E4. Anyone who is a blood child of that individual has at least one copy of the E4 gene. They're at least a heterozygote, and the genetics of that are very well worked out. My point is that the testing for the ApoE4 gene to inform your risk of developing ARIA is also a test that informs familial risk of developing Alzheimer's disease, adult children, siblings, etc. I bring this up because I think it adds some complexity to decision-making about pursuing ApoE testing. Next, I'll talk about the key points about how we reduce the risk of ARIA. You need to undergo an MRI scan to look for microscopic hemorrhages and edema. Most, as I said, are asymptomatic. To receive an infusion of the drug, it is utterly contingent on an MRI being done and scheduled safety MRIs afterwards. And so one of the points I wanted to emphasize here is, if you're going to take the drug, you want to look ahead in your calendar, and we'll give you information about the scheduling of the MRIs to make sure that you're going to be able to get the MRI done. So if there are plans for long vacations to faraway places soon after starting the drug, that's probably not a good idea. In part, first of all, you've got to get the infusion every 2 weeks, but also you need to come in to get the MRI for a safety check. If we detect hemorrhages or edema, it's the it's the presence of edema and symptoms that would inform the decisions about whether to continue, pause, or halt treatment. Knowing what those symptoms are, of course, can help, and we'll be giving people a symptom checklist to look so they can know what kinds of events often signal the need to come in even to get checked out, like a headache, gait instability, or vision changes. We'll also be educating you about the medications to avoid, or certainly at least to consider carefully, medications that can increase the risk of bleeding, like anticoagulants and blood thinners. So that's an overview of the risk of ARIA. Now let's talk about the benefit. In David's talk, he's going to talk a lot about a measure called the CDR, which is an abbreviation for the Clinical Dementia Rating. The CDR has been around since the 1990s. It was developed by investigators at the Alzheimer's Disease Center at Washington University in Missouri. This is a screenshot of their webpage, and you're welcome to go visit it. It's to their page dedicated to the CDR. It's copywritten and only available to be used if you've paid for the copyright use. It is one of the main measures used in the studies of these anti-amyloid drugs to determine whether it's benefited the patient. I thought I'd give you a basic overview of the CDR so that when David talks about the global CDR, you'll understand what the global CDR is. David's also going to talk about the CDR sum of boxes, and I hope it becomes clear, or clearer at least, what he means by global and sum of boxes. Well, here's the CDR. Whoops, my cursor just put myself in a place I didn't want to be. On the left, you see the CDR rating sheet. And what I'd like you to notice is that at the top there, I'm looking for my cursor, I can't, oh, there we go, I don't know if you see it, but none, questionable, mild, moderate, severe describe the overall stages of dementia caused by Alzheimer's. None, of course, means you don't have any symptomatic disease. Questionable means you're somewhere between having mild stage disease and none. We often kind of think of this as the MCI stage. Mild is mild stage, moderate, severe. What a great, and then along this, the rows are memory, orientation, judgment, decision-making, and so on, namely the 6 criteria with which a clinician makes an assessment. And as you can see, and we'll take memory as an example, you assess the individual's memory using a set of standard questions, and based on your answers, you decide which of these 5 boxes best describes the individual. We'll talk in greater detail on the right side about that. My point is this. You rate a person on each of these rows, putting in each of a box for each row, and therefore you could sum up those boxes to arrive at a sum of the box score of how the person's doing. That's a quirky way to use the scale, but it is used. What it generally is used is you enter those answers into an algorithm, and that algorithm pops back a stage. In other words, it says, given where you put all the person in each of the boxes, they categorize into a 0.5, or they fit into a 1 or a 2. And that's considered an overall staging, or if you will, the CDR global. In gold or yellow, I highlighted to give greater detail over here, that over here, the particular area of the CDR which is focused on for the people who got these drugs, because as David will explain, these drugs were prescribed to individuals with mild cognitive impairment or mild stage dementia, meaning people who generally fit into the boxes here. And I've tried to highlight here individuals on the memory scale who would get a 0.5 versus a 1, just to show you the kind of language and judgment that's used to describe the judgments that's used and the language that informs that judgment to put persons in one box or the other. So that's an overview of the CDR. It is the measure of benefit used to establish these drugs' benefit to you, to individuals, to patients. And now I'm going to turn it over to Dave to dive deeper into a review of donanemab, whose results were released just a few weeks ago at the International Alzheimer's meetings, and also in a publication in the New England Journal of Medicine. Dave, why don't you take it away? The screen share is yours.
Thank you so much, Jason. And thank you all again for attending. I am going to try to set up so I have a laser pointer. There we go. And that will help sort of point out some of the specifics. I do just want to say that, really what an exciting time in this field. I think, having these kinds of discussions are things that Jason, myself, and many of our colleagues have wished for a number of years to start to really think about therapeutics in a much more effective way in our patients. And so, I'm very excited that we're bringing these medicines into practice. So let me talk about the donanemab phase 3 trial results. So just to let you know, phase 3 trials are often considered the sort of definitive trial for a drug to determine whether or not it's safe and in particular efficacious for treatment of a particular condition. And it's the trial that is then used for the FDA to make determinations about whether or not to approve the drug. And as Jason mentioned, data for this phase 3 trial from donanemab was presented in the meeting in Amsterdam at the Alzheimer's Association International Conference just a few weeks ago. And so we're still sort of digging into that data. The trial was called Trailblazer-ALZ 2. There was a phase 2 trial that came before it, which also was called Trailblazer. And those phase 2 results I should note, are very, very similar to what was seen in phase 3. And the reason why I bring that up is just to support the idea that there's some consistency in different data sets with this drug in terms of showing its effectiveness. Donanemab is a antibody. It's an antibody that's given to you as opposed to your body creating it itself to target a protein in the brain. And in this case, it's targeting amyloid beta. And in particular, it's targeting the amyloid plaques. So it's very specific to the one of the defining features of Alzheimer's disease, which are the plaques, which are these kind of clumps together of the amyloid protein that are what we call insoluble. They're not in solution, so you can actually physically see them under a microscope. The reason I bring that up is it is one of the differences between this drug and lecanemab, or Leqembi, in that lecanemab is more targeted towards a more soluble form of amyloid called protofibrils. And so that may tell us or may have impact on the effectiveness or differences perhaps between how the drugs work. They're not the exact same drug. The trial was quite big. It included about 1,800 people or about 1,700 people. All of them had either what we would call mild cognitive impairment or mild dementia. For those of you who kind of know scores with the Mini-Mental Status Examination, which is a very standard test, the range was 20 to 28 in the study at screening. The age range was actually a little bit more narrow in this study than it was in the lecanemab studies. It was between people 60 to 85. And importantly, just like lecanemab, this trial required amyloid status to be confirmed with an amyloid PET scan, which is a imaging study where one can actually visualize the amyloid plaques of Alzheimer's disease. But what was unique about this study is that it also required a tau PET scan, which involves a tracer that tells us about the other main hallmark of Alzheimer's disease, that is of the tau protein, which forms what are called neurofibrillary tangles. And one of the things that this trial did was they staged how much tangles there were in the brain in individuals who were amyloid positive, such that they excluded people who showed no evidence of tau pathology in the brain based on this PET study. And one can argue with tau PET that because tangles relate to symptoms, when tau is negative, people don't tend to change a lot over time. They tend to not have significant symptoms at that point. And so to enrich the study in people who were more likely to show change over time, they required that you at least had a low to medium level of tau pathology. And that was the core group that they were targeting, because there's a belief that these drugs are going to be more effective when people are in mild stages of disease. But they also included people who have so-called high levels of tau pathology in the brain to test whether or not this group would be responsive as well, or at least this group in combination with the other. And these are just images of like average brains of this tau PET pathology and where they are in the brain. So how was the study set up? Well, like almost all phase 3 clinical trials, it was a placebo-controlled study. So half the people got the drug, half the people didn't get the drug. They got monthly infusions of the drug as opposed to the biweekly infusions of lecanemab. Interestingly, amyloid PET imaging was done at baseline to decide, as I mentioned earlier, whether or not you could get into the study, but it was also obtained at 24 weeks, 52 weeks, and then 76 weeks, which was the end of the study. And one of the things that was, I think, a clever design in this study was that the drug was discontinued if you were considered amyloid negative at weeks 24 and 52. And what that means is where the amyloid PET was repeated and you no longer showed evidence of elevated amyloid in the brain, because presumably the drug had removed the amyloid from the brain. And their argument was that if these drugs treat the plaques of the disease, if there are no plaques of the disease, there's not a reason to continue the drug at that point. And so there were what we call criteria based on amyloid PET imaging. And I'll show in a minute or two how many people kind of reached those criteria. Their primary outcome, they used one scale that's called the Integrated Alzheimer's Disease Rating Scale, and it's basically a measure of both thinking, memory, and other aspects of cognition, as well as function as a kind of combined scale. But there were many other outcome measures that they looked at, including the clinical dementia rating scale that Jason mentioned earlier and that we'll focus on. Just a couple of features about the population that they studied in this phase 3 study. One is the age. So their mean age in this study was around mid-70s, which is typical of when Alzheimer's disease tends to present in individuals. I think really important to point out, this study, like many other phase 3 clinical trials and actually other studies within our field, actually did not do a great job of representation in underrepresented groups. So Black and African American individuals made up only about 2.5% of the population, and Hispanic or Latinx individuals made up only about 6% of the population. When thinking about the level of impairment, the mean mini-mental status examination for this group was 22.3. And I just point that out that differs from lecanemab, where the mean mini-mental was 25.6 out of 30 in patients. And the mini-mental is a 30-point scale. And so this difference suggests that the population studied with donanemab was actually a bit more severe than the population studied in lecanemab. And in fact, only about 20% of the patients in the donanemab trial met a mild cognitive impairment classification based on mini-mental status examination score. So still mild cognitive impairment, mild dementia, but a bit further along in the disease, likely because of the requirement of tau PET that differs with the lecanemab study. So what did the drug do? Well, I think really impressively, the drug hit its target. It had what we call target engagement, and that was showing reduction of amyloid over time. And so what you're looking at here, so that x-axis is time. So these are weeks after starting the drug, and 76 weeks was when the trial ended. And the y-axis represents amyloid levels on a PET scan. And 0 is the baseline. So if you go down, you're lowering amyloid in the brain. And what you can see is in people who aren't treated with the drug, if anything, there's a little bit of an increase of amyloid in the brain over time. Although by this stage of disease, amyloid tends to kind of level off the way you see it here in untreated people. But really remarkably, even just 24 weeks, there was a real significant reduction in amyloid levels, 52 weeks even more, and even greater by 76 weeks, where it was over 80 on this scale. And 80 on this scale, which is one of the standard scales for amyloid PET, reflects a really, really substantial change in amyloid status. And in fact, about a third of people were amyloid negative by 24 weeks, and actually almost 3/4 by 48 weeks were amyloid negative. And so many of these patients stopped taking the drug, went on to placebo at that point in the study, given the stopping criteria I mentioned earlier. So great to see changes in amyloid. That's very cool that we're able to do that. How does it actually impact the clinical status? And that's really ultimately what we're going for here. And these two scales show performance of the drug, its impact on clinical outcomes in that really targeted group, the group with low, medium tau, who are the sort of primary group of the study. And on the left is one using that scale I mentioned earlier, the IADRS. And what was seen was that the placebo group had a faster rate of decline than the donanemab group, which actually was fairly steady to begin with, and although still did decline over time, but that difference between the groups seemed to widen throughout the course of the study. And overall, there was about a 35% slowing on this particular measure during the course of the study. Same thing was true with the CDR sum of boxes. Again, there was a widening of the difference between the groups over time, favoring the donanemab group, but about a 36% slowing in kind of quantitative terms. In absolute terms, there was about a 0.7 difference on that CDR sum of box scale. There was some data within the study that supported the notion that the efficacy of this drug may be less potent in people who are further along in the disease than that low to medium tau group. So this is just showing you the same image again of the 35% slowing in the low to medium tau group, but in the high tau group, there was only a 22% slowing. I should note that the absolute differences between groups were pretty similar when you combine the high group with the low and medium, but because that absolute difference is a smaller proportion of change over time when you include people who are progressing faster, the percent slowing is less in that particular case. As a secondary analysis, so not powered for the kind of rigor that we are required for making sort of definitive statements in science. There was also some data to suggest that the drug may be more efficacious in the most mild patients from the cohort. And so this was looking at those individuals who were at the mild cognitive impairment stage as opposed to mild dementia in the study. And what was seen on both scales we just mentioned was a 60% slowing or a 45% slowing on the CDR sum of boxes by the end of the study. So an increase in the sort of relative amount of slowing in people who were in a mild stage of disease. Although in general, I should say both groups, when you really dig into these scales, don't show a lot of change over time, but certainly seems slower in the treated group. One of the things that I think is really important and was presented at the meeting is, well, we don't really know, should we stop the drug when people are amyloid negative? I mean, that's the assumption, and it's based on the kind of conceptual idea that the drug is targeting plaques, and why treat plaques if they aren't there. But I think this particular analysis really tries to dig in a little bit more. Well, what happens to these patients who are put on placebo? Does it seem like they don't do as well, or does the effect start to go away? And while this is a relatively brief period of time in the sort of natural history of Alzheimer's disease, this particular analysis used only the people who were treated on the drug who actually stopped the drug due to hitting the criteria of getting to an amyloid negative status. And on average, people reached that point at about 47 weeks. And what is shown here is that even though the drug was stopped in the majority of people at 47 weeks, the effect of the drug in slowing down the disease continued to widen over time, supporting the idea that once you're amyloid negative, you don't necessarily need continued treatment to get the benefit of the drug. Need lots more data on this, but that's definitely a very compelling piece of information, and something that we all want to learn more about in the future, because it would be great to be able to stop these drugs and not keep people on them for really long periods of time. So Jason talked a little bit earlier about how do we think about benefit in these drugs, and I presented like percent differences and scores, and those things are often really hard to kind of wrap your head around. One way that I think some people find useful to think about these drugs is what kind of reduction in risk do they produce for maintaining a particular level of clinical impairment over time. And so that's what this analysis did. And I'll walk you through it, but basically it looked at that CDR global score, which, as Jason mentioned earlier, kind of defines different periods of time in the disease, a sort of intermediate or indeterminate, a mild, a moderate, and a severe. And so what they looked at in this study was what proportion of people on drug and what proportion of people on donanemab went to the next stage of disease during the course of the 72-week study. And what this figure shows you is the y-axis is the percent of people who went on to that next stage. And so in the placebo group, about 30% of those individuals progressed to the next stage of disease, which would be a kind of clinically relevant change from mild cognitive impairment to more significant mild dementia level impairment where function may be more affected. Whereas the donanemab group, about 20% of them went on to that next stage. And so a lower proportion, reducing your odds by about 38%, that you would move on to a later stage of disease within the 72 weeks of the trial. There are a couple other ways one could consider the drug benefit that have been bandied about. And again, I think for different people, they may help sort of frame in their mind differently the benefits of these drugs. And some might be more useful than others. One is another way that one can conceptualize is the degree to which donanemab benefits individuals is kind of how much does it slow the disease progression in time. And so based on the scales that we were just looking at, over 18 months, one could say that you've gained anywhere from 4.5 to 7.5 months, depending on what scale you used. Another way, and I think that could be a useful way of thinking about the efficacy of these different medicines, is how much does it keep you from being completely stable versus, or how much does it maintain complete stability when you take the drug versus not? And so in this particular analysis, they looked at the CDR sum of boxes, that total score, and just looked at what proportion of people showed no change over the course of a year versus people who showed change. And again, in this case, the treated arm, about half of the people on the treated arm did not change over a 1-year period on this scale at all, whereas 29% in the placebo group stayed stable, meaning 71% did progress. And so that's another example of where the drug helped to maintain stability. And then finally, I think one can actually go into those scales themselves that Jason showed earlier and say, well, what does a 0.5 or 0.65 mean on these scales when we think about how they're scored? And a 0.5 difference can mean the difference between consistent slight forgetfulness on the scale versus more moderate memory loss that interferes with activities of daily living. And so these are just different ways of conceptualizing how the drug benefits individuals. I don't think there's any right or wrong answer to it. Just to talk about the risks of donanemab, there were 16 deaths in the treated arm. There were also 10 deaths, though, in the placebo arm. And I think it's important to point out that patients, these are elderly patients with multiple medical issues oftentimes. And so we do see in all of these trials some degree of deaths during the period of 1.5 to 2 years of the studies. 3 of them, though, were considered related to donanemab. One death, actually, interestingly, in the placebo group was thought to be related to the drug, although the person was obviously on placebo. So there are fatalities with these drugs, and that's, I think, really important to know. Less, very, very small percent, but certainly there. In terms of ARIA, about 1/3 of individuals with donanemab had an episode of ARIA, whereas about 15% on the placebo group had an episode of ARIA. 6% of ARIA was symptomatic in the donanemab group. So about 52 people exactly had symptomatic ARIA. 45 of them, so the vast majority of them, had resolution of their symptoms, but a few of them maintained having some more prolonged impairment due to ARIA-E. And in general, there was about a 1.5% risk of a serious adverse event associated with ARIA. And usually in clinical trial parlance, serious adverse event means being admitted to the hospital or having something that impacts your function or neurologic status. Again, most ARIA-E was very mild, just on imaging, mild to moderate, and it was strongly related to ApoE status. One thing I think that gets a little less attention is infusion reactions. These drugs are associated with sometimes an allergic type response that people can get when they're being infused with the drugs. Those generally are very mild as well and can be pre-treated, and over time they tend to go away with individuals as they come back for additional infusions, but in a few cases can be relatively serious and can involve more significant or emergent kinds of interventions. Again, as Jason, I think, really well explained, so I won't delve into this in too much detail. ApoE status, whether you don't have any copies of the gene, you're a non-carrier, you have no copies of the E4 allele, whether you have one copy, heterozygote, or two copies, that really influences the risk of ARIA. So it goes from 16% for the swelling or edema to a little bit increased in those that are heterozygous, but much, much higher in those that have two copies of the gene. And the same is true when we look at ARIA-H, which are those microhemorrhages that Jason spoke about earlier. One thing, though, that I do think is important to point out is that these ARIA events are part of Alzheimer's disease, and they also are related to ApoE status. So microhemorrhage is not uncommon in Alzheimer's disease, particularly if you have two copies of the E4 allele, and that's as seen in the placebo group, where these individuals weren't treated with drug, and there's some rate of ARIA-E and certainly a much higher rate of ARIA-H. And so these things occur as part of Alzheimer's disease, but these drugs definitely increase the risk of them and likely increase the severity of their occurring. So just briefly, a comparison between the two drugs. I've sort of said a lot of this already. They involve different degrees of impairment in terms of the trials. Another way of looking at this is CDR global measures, and generally the point here is that donanemab involved more impaired patients. Both drugs required amyloid confirmation. When we look at amyloid using that scale that I mentioned earlier, centiloids, it was higher in the donanemab group by about 25%. Again, all these things just showing that the donanemab group involved somewhat more severe patients. Only donanemab required tau PET in its study. One really important point that I mentioned earlier is one of these drugs, lecanemab, is every 2 weeks, whereas donanemab is every month. There are amyloid stopping criteria only for donanemab at this point. And the duration, it's hard to know. It's for lecanemab at this point. Right now, an instinct would be just to treat people indefinitely. And for donanemab, for those who didn't meet stopping criteria, those it's a little unclear too, although we would think that they might be stopped when they ultimately show some degree of amyloid clearance. And again, in terms of FDA approval, lecanemab has full approval and donanemab has no approval, but we expect it in the next 6 months or so. Just comparing the benefit of the drugs to patients, if you look at the CDR sum of boxes, it's pretty similar in absolute terms. It was a little bit larger in the donanemab group. And again, looking at that reduced or benefit of stability on the global CDR, the rate of stability was a little bit higher, or you gained more with the donanemab than placebo in these studies. Again, keeping in mind the differences in the population. And then when I'm talking about risk, I think one thing that does seem to be pretty clear is donanemab in general seems to be associated with higher risks of ARIA. There's lots and lots of numbers here. Both of them show the same increase in risk based on whether or not you are a non-carrier, heterozygote, or have both copies of the E4 allele. But in general, the rates of ARIA-H and ARIA-E, ARIA-H again being the microhemorrhages and ARIA-E being the edema, is higher in the donanemab group. Again, different populations. So I will turn this over to my colleague again, Jason, now.
Jason, you are muted.
All right, I'm unmuted. Woo! Sorry about that. Thanks, Dave. Sorry about that. Again, lecanemab, FDA approved, soon to be prescribed at Penn, and we'll give you an update on that. Donanemab, not yet FDA approved, but I think if the data hold up to what we've seen, FDA will certainly get a close look at it, but we expect it also to be receiving full FDA approval. So let's talk about what we've got here. Dave, which drug's better? Now, the evidence-based medicine doctor says, I want to see a clinical trial that compares donanemab to lecanemab head-to-head. Do we have that data?
Yeah, so we don't have head-to-head data, and I think as I tried to allude to a number of times throughout the presentation, the populations that were studied in these two trials differ, and they differ based on how individuals were selected to be in those studies. And the donanemab study basically enriched in a group of people who were more likely to decline over time. And so to some extent, there was more room for evidence of slowing of what's a slow moving disease to begin with. And so it's a little hard to compare the benefit of the drugs to each other. The risk has the same kind of general issue where they are different populations, although there's a hint at least that donanemab may be associated with more risk. But the way that you apply the drug is one difference that's indisputable, which is one of them is given monthly versus the other every 2 weeks, and there are these more kind of clear stopping criteria. So I don't know.
Yeah, so I think what we're getting at here is, I think, and in general, in my conversations with colleagues, it's just that we don't have a head-to-head comparative study. I have a hunch one's going to happen. And if you compare the two studies, there's enough differences that it's hard to just clearly conclude one is obviously better than the other. Having said that, then I think the next question is, how do I decide if one of these drugs is right for me? So in other words, what things should I be looking at? And I guess one of them would be, well, how well do you fit the core eligibility criteria for the two drugs? Any thought? I mean, you have to have MCI or mild stage dementia. You have to have amyloid. Are there any other core eligibility criteria that would tip you one way or the other?
Yeah, I mean, I think that certainly with donanemab, if we follow the trial itself, tau and level of tau may influence, the likelihood of effectiveness, of the drug based on the data they showed. The problem is we just don't know that in the lecanemab study, and so it would be hard to use that as a tipping point.
I don't think we can't routinely get tau imaging.
Yeah, and so that's another issue is right now we're not able to get reimbursed for tau PET. Maybe that'll change in the future. I hope it does.
So I guess it would be things like the frequency of dosing, how much it costs. So these drugs, if you don't have a good copay plan, there's an out-of-pocket cost here. Lecanemab is about $26,000 a year. That could cost someone several thousand in a copay if you don't have a good copay. So that might be another factor that someone would consider.
Yeah, and I definitely think that one of the biggest will be, as you said, just in terms of the ease with use of the drug. So people going away and some of these other kinds of just life considerations are going to play.
You've got to get an MRI start. You've got to get a safety MRI along the way. If you don't get the safety MRI, the dosing ceases. That's one of the plans we have. And then finally, of course, is the need for ApoE testing. So I think how to decide what's right for you. Do you want to get ApoE testing? Can you get an MRI? Can you come in for infusions, et cetera? Well, I guess that leads us to, all right, if I think I want to take the drug, but how are you going to know the drug is helping me? How are you going to know it's doing something for me? So we talked about those various ways to measure benefit. Let's start. Are we going to measure amyloid to know if it's helping me?
It's a little unclear at this point, what we'll be doing in terms of what's available for us to test. I think certainly, again, the donanemab study supports the idea that they want to know someone's amyloid status over time to make decisions about whether to continue the drug or not. It's a little less clear with lecanemab. I think personally, these drugs target amyloid in the brain, and I would want some evidence that it's hitting its target in individual patients. And so, I sure do hope that we'll have some ability to get follow-up amyloid PET scans or other amyloid
Yeah, maybe
measures.
like after a year of therapy, repeat a PET scan, or perhaps by then, or we'll have the ability with some of the blood tests. I think that's a work in progress, but I think many folks when I talk to say, gee, clearance of amyloid would be a nice way to know it's time to stop the drug. What about looking at things like what other kind of clinical measures would we look at? How would we decide what clinically someone's benefiting?
Yeah. Yeah, I think, we'll have to do what we normally do as clinicians, which is, assess people's cognitive functional status. I think it will be helpful to use some standardized scales like that were used in the study to get a sense of how people are doing over time. I mean, one of the challenges here is that, and particularly in the sort of construct of the 18-month trials that these drugs were done in, is that even in the placebo arm, you'll notice that a lot of people don't change a lot over that period of time. And so it's going to be very hard to know in individuals who don't change over time, is that because the drug is doing that, or that's just the natural history of the disease? What I would say is if we're seeing people declining more rapidly, that would be a red flag that something is not going well with the drug, and maybe something that would lead us to reconsider use of it.
Yeah, because I think, we know from anti-amyloid therapies going back to some of the therapies whose names I can't even remember, they were tested so long ago. Many of them were very good at clearing amyloid, but had no effect on clinical measures, given the species of amyloid they were targeting, et cetera. We won't perform autopsies or obituaries on those drugs. So I think the lesson to the field so far is amyloid alone isn't telling you the total story that someone's doing well. You need to look at some other things. Could we think, in addition to those clinical measures, maybe someday measures of tau protein or neurodegeneration might tell us whether neurons are living or dying?
Yeah, no, I think that's really important. And, there was, at least at the meeting we were just at in Amsterdam, some data supporting the idea that downstream markers of the disease may relate to clinical outcomes.
What's the downstream marker of the disease?
So things like measures of tau, or things like measures of neurodegeneration may have value in sort of saying who are the people more likely or less likely to be benefiting from the drug.
I think what I'm hearing in the field and this conversation is, these are early days, but the measured brain is going to become part of what we talk about when we talk about treating Alzheimer's, and I think someday diseases like Lewy body disease and TDP-43, namely various ways to measure how's the brain doing, other than, in addition to, I should say, the measures of the mind, if you will, cognition, function, behavior. What is it like to be? Yeah. Well, let's pivot now. That's how it's helped. Should I take it? Is it right for me? How do I know it's going to help me? But let's flip to the other side, is how are we going to maximize the safety of the drug? And I certainly sort of developed this in the beginning remarks. You further developed it. It's pretty clear you've got to be able to get an MRI, right?
Yeah, no, I think it's
no MRI, no drug.
Yeah, I think the MRI is critical. So if you're not able to get an MRI for some reason, I don't think this is inappropriate.
Yeah, I don't think I would prescribe it if someone says, I don't want to get one, I can't get one. What about ApoE testing?
Yeah, so I'm with you, and I think this has largely reached consensus within the field, is that, when we give a drug and when people decide to take a drug, they want to know what the risk-benefit trade-off is. And we don't know the risk without knowing the ApoE status. So I would feel very uncomfortable with giving the drug if I'm not aware of that, to at least help have a better understanding of what that sort of ratio is.
Yeah, I mean, if ever there was, the whole promise of genetics back when Clinton said we're going to sequence the whole genome, and the Human Genome Project was launched, was precision personalized medicine, my genome myself, which actually I don't think is correct, but setting that aside. So here's a good example. If I can get you a gene test that's going to help inform how risky this drug is going to be to you, recognizing that most episodes of these hemorrhages and edema are asymptomatic and a non-issue if they're detected. But it's certainly going to help to know where you're at on that risk ladder. But of course, we have to remember, and we're going to talk about this with people early on in the decision, if I tell you you have an ApoE4 gene, you have information that is relevant to blood relatives, adult children, siblings, etc. And not to be a joke, but there is, if your adult children don't have the E4 gene and you have 2 copies, they're not your blood children, maybe. But that's a different story for another time. Um, so how do you know? Let's just hammer this down. How do you know if I've had these side effects? What's the ways that you're going to tell me, or we're going to find that out?
Yeah, so I think you know, one way we're going to find that out is through these MRI scans, which are, they can be thought of as kind of surveillance MRI scans. They're looking at the brain during a period of time when you're at highest risk.
And those first few months of infusion.
Yeah, for sure. And so that's going to be one way. And there are, you know, strategies around when you do see changes. Sometimes you actually continue to treat people if they're asymptomatic and really mild. Other times you need to pause the drug for a period of time and let them resolve.
And I think what we've learned is like the way we say, well, it's only mild, is this: you had no microhemorrhages, now I see one.
Yeah.
And we have these kind of criteria. We're not going to detail them about how many new microhemorrhages, as well as the presence of edema, et cetera. So it isn't that the moment there's one, we stop it. It's we have these criteria set up to make a judgment.
Yeah, absolutely. And the other thing I'll say, that the other way we'll find out about whether or not people are having these side effects is if they start to have symptoms that will, you know, make us want to sort of better try to determine whether or not that's due to ARIA.
And those some of those things are headache, vision changes, gait changes, right? Those seem to be kind of common ones. Of course, headache is very non-specific, but you know, early on in the course of therapy, I just got my infusion. 1 week later, you know, I'm a little wobbly and my head's a little, I would give a holler, come on in, let's get an MRI.
Yeah, absolutely. I think, you know, as we're learning with these drugs, I think initially there will be a tendency for us to take all symptoms, you know, pretty seriously and want to, you know, get imaging to better determine whether or not they're related to the drug.
So what do we wish we knew, but right now we don't? And this is just about these drugs, Dave, not about
life.
Yeah.
Yeah, no, there's actually, I would say with these drugs, there's actually a lot of stuff we still would want to know in addition to beyond these drugs. You know, I think one of the probably one of the most important things that we don't know yet is what happens after 18 months with these drugs, because again, there's this idea that the drugs, the difference between groups is expanding over time. And but 18 months in the world of Alzheimer's is a relatively short period of time in terms of progression. And so if these drugs continue to show that expansion after 18 months, then geez, this drug really is potentially making a very large impact on individuals. Whereas if, you know, after 18 months, those lines start to become parallel to each other, then there's some benefit, but it's a much smaller benefit. And we just don't know that at this point in terms of their long-term efficacy.
Yeah, yeah. Well, again, these questions are based on the many questions we got that we made our best effort to sort of synthesize into what we thought were the core kind of 6 themes we were hearing. So if we kind of think about who's a clear candidate for the medication, well, putting everything together that Dave's talked about, that he and I talked about, what we're looking at is someone who has MCI or mild stage dementia. When I think of MCI, I think of cognitive impairment that's causing inefficiencies, takes you longer, you make mistakes, but you catch them. Whereas mild stage dementia, consistent problems that require some assistance. This person values slowing the disease. They want to sort of keep things the way they are now. They obviously have elevated amyloid. Their MRI screening shows no microhemorrhages. Many people over the age of 60, 75, the average age 75 for donanemab, have cardiovascular disease, hypertension, high lipids, but that would be stable, and they're not on any medication that can increase the risk of bleeding. They have ready access to an MRI, not a problem getting one. In fact, they enjoy getting them, perhaps. They have ready access to an infusion site. They have no ApoE4 gene. They have someone to watch over them who will notice any changes, help out, come in for the infusions. And perhaps even has received one of these drugs in the past, such as in a clinical trial, because that means they obviously have experience. If all these things would add up to someone who, again, I think that second bullet is so key, because this is a very personal choice about whether to slow the progression of the disease, extend the time living with this disease. Only you as an individual know what it's like and therefore what you want it to be like. Obviously, if someone has some of these, doesn't have some of these characteristics, they're still a candidate, but we wanted to kind of outline sort of what would be someone who everything seems to be in line to go ahead. All right, well, with that, what's the story to come? Well, Penn Medicine and David, Dr. Vaishnavi, myself, and other colleagues, we've been working to develop a workflow for the delivery of these therapies. And we expect to begin a pilot in August or September. Remember, we did not have these therapies a year ago. So we have no infrastructure in place to deliver infusion therapies with all the complexities that you've seen. So we've gone from nothing to something fairly rapidly. And so we're going to begin a pilot to work out the kinks and get these therapies available. I'm saying therapies, plural. Right now it's a therapy, lecanemab. Again, we expect donanemab will get FDA review in the next 6 months. And if the data hold up what we've seen, I think it will likely get approval. And we'll see what FDA does, but the black box on lecanemab, I would expect perhaps will carry over to donanemab, that learning about the risk of ARIA related to ApoE. When this event ends, we'll put another chapter to a very exciting story of the development of anti-amyloid therapies, biomarker-based diagnostics, and Alzheimer's disease. We very much want you to fill out a short 3-question evaluation of the session. It helps us know if we've done anything right, what we can improve on, and we always like a few compliments here and there too. We really want to learn from you though. Let me wrap this up with this point. What's your plan to receive or not to receive? As you reach that sort of plan, if you're willing to share your story with us, we really want to hear it. And I have here the email to reach us, pennmemorycenter@pennmedicine.upenn.edu. If you're willing to share your story about how you reached your decision to receive or not to receive the drug, we need to hear that. We need to learn what it is that you think about. What is it that you care about? What were the factors that drove you to one way or the other? That's really important because that's the voice that will ultimately decide how the standard of care is rolling out, what matters, etc. This is not an easy decision to make. The drug does not cure the disease. It does not halt the disease. It does slow the disease, and slowing a disease that's chronic and progressive means something to people. I know this personally from family members, but I also know it's a difficult decision because it's a difficult, complicated disease. So if you're willing to share your story, we'd like to hear it. And again, you'll have an opportunity when this ends to perform a short 3-question evaluation. We'd very much like to hear that. I'd like to now turn it back over to the Master of Communications for the Penn Memory Center, Terry Casey.
Thank you both for your time and attention, and everyone, all of our guests today. This was the largest of our community conversations, and I think it just shows just how much passion and thirst for knowledge on this topic there is, and how much there is to come. And so we will have this has been recorded. We'll have it up on our YouTube page tomorrow morning, and then we'll have it in our Insight edition on Wednesday. We'll also have more information listed then for our website. The page is dedicated to the anti-amyloid therapies and the drugs mentioned today specifically. But again, if you don't have, if you have questions that you feel were not answered, please use the email address. I dropped it in the chat as well, so you could just copy and paste it, or you could just reply to the next email you get from the Penn Memory Center, and that'll come to my desk. If we can answer a specific question and we'll get it back to you, we will. If we think that your question it represents a kind of a broader population, then we'll loop it into our Q&A and put it up on our website. So thank you again to Jason and Dave and to the 208 some attendees that we had today. So appreciate everybody's time today.
Thank you.
Bye, Dave.
Bye.